We are going to learn about the management of pain. This will be taken by Mr. Sudip. You all know him. He took the last week session for us, that is Introduction to Pain. Sudip, come back and over to you.
Thank you, Shiva. So please confirm once again, you can see my slides.
Yes, your screen is visible.
Yeah. Is it okay now?
Yes, yes.
Okay. So today I have some internet issue. So I'll be keeping my video off. Okay. So before going to the management, we have to know the principles of pain management. So there are little principles like by the clock, whatever the medications we are giving, it has to be, the time has to maintain properly. By the ladder, we will know about the WHO analgesic ladder. Some of you may already know, but for all others, I'll explain once again by the ladder. What is WHO analgesic ladder? Next is by the class. That means the same class medication, two medication we should not use at a time because there might be some side effects. Instead of getting the good effect, we might get the side effect. So whatever the medications we are giving to our patients, we are administering to our patients, we have to be very careful so that we should not use the same class medication repeatedly. Next is attention to details. What is attention to details? I'll explain later on the ones in my next slides. What is by the class? So basically in WHO analgesic ladder, we have different class like non-opioids, opioids. So whatever the class medications, like whatever the medications belongs to the what class, we should not use. So maybe suppose diclofenac, aceclofenac. Both of the medications belongs to NSAID. Okay, so patient is getting diclofenac, patient is also getting aceclofenac. There will be no use. Okay, just NSAID dose will be more and patient might develop other side effects, associate side effects. Man. Opioids, in case of opioids also, if we use the same for the same patient, if we use the two different opioids at a time, so maybe we can see some of the side effects of opioids. So we have to see those things. Next is whatever the medication we are giving to our patient, it has to be like painless. So suppose patient came to our OPD or patient came to our hospital with like poor management of pain. Instead of the like poor management of pain, and the patient can be managed through oral medications also, but we are trying to put cannula, IV cannula, IV intra cannula. So if we are pricking the patient's number of time, instead of giving her pain relief, we are introducing her to the more to the pain. So we are increasing her suffering. So that's why oral route is always the preferable route. But if in some conditions that we have to take the immediate response or like to the, and we have to administer the intravenous injections or all, then we can go for it definitely. But always it's the oral route is the preferable route. What is attention to details? There was one point, no? Attention to details. So first is correct the correctables. So basically, if the patient has some precipitating factors like cough, constipation, which is associating the patients or which is increasing the severity of patient's pain, we can correct those things, or if the patient is already in some anti-cancer treatment, if it is not that much of effective for that particular patient, we can just ask that medical oncologist or radiologist, so will it be possible to keep give a gap in between the treatment, so that the patient, there is like chemotherapy induced neuropathy, or maybe radiotherapy induced muscle spasm, so those things can be prevented, or those things can be treated properly. So that's in correct the correctables. What is non-drug therapy? There are also some non-drug therapy like positioning. Sometimes patient has the problem with the particular position, basically head and neck patient. Okay, after giving after going through some surgery, so their postural problem is there. So if they are not maintaining the normal posture, or because of the surgical procedure, if their posture is affected, then maximum of case we have seen that they come up with muscle spasm or some musculoskeletal what to say this muscle pain. So that positioning is more effective for that kind of patient. Next, the relaxation therapies. And like, if some of the patients, if they are going through some of the drugs, so what kind of drug the patient is taking, whether the patient is taking the drug or like timing are okay or not, if patient whether the patient is taking the correct dose of the medications or not, when he or she has taken her last dose of medication, these are the things we have to give the attention, so that we will come to a conclusion that okay, for this particular patient we have to do this 1 2 3 4 5 things, because the patient has already done whatever he could do. So now we have to go for the next step. That's why attention to details are very necessary. We have non-pharmacological measurements, we have medication pharmacological measurements. Pharmacological also effective sometimes, sometimes non-pharmacologicals also are more effective than the medication. So we always prefer that non-pharmacological and pharmacological management should go equally, parallelly, so that the effectiveness of pain management should be more. Next is teach the families to prevent pain. So next is maintains the stable analgesic blood level. How we could maintain the stable analgesic blood level, then how we can do the baseline control of pain, and then how they could do the pain assessment even their home environment. Suppose we have given medications to the patient, and we are ask them to take the medications at home, and after few days they came to our OPD and informing that whatever the medications we have given, this is not working properly. So they have to answer that okay, when it was not working after taking medication, since how long your pain was not there. So the caregiver has to get the proper teaching how they could do the pain assessment in their home environment. That is one. Second is, if they are taking some of the extra doses like SOS dose, some of the medications doctor used to write that okay, you are going through with this tramadol, you are going through with this going with this morphine or maybe so, but keep this one as like SOS medication. Some of the medications, if they could give SOS medications and they are taking at home, how many doses they have taken, which date, at what time, so we have to ask them to write in a copy, and while they are coming for the visiting in the hospital, they should bring that copy, and we can reassess the patients that what are the things we need to again reevaluate it and give the medications properly. Some of the non-pharmacological therapies like physiotherapy, exercise, hot and cold application, meditation, music, distractions, massage, homeopathy, Ayurveda, and some home remedies. Now, here one thing, music, distractions, all are there, but it depends on the patient's severity of pain, patient acceptance. Suppose patient came to you with a severe pain and you are asking, okay, I called your doctor, he is on the way, he is coming. By the time you please listen the song, he will just kick you out. Because in such condition, whenever the patient is in severe pain, he or she is not in the condition to listen the song. So whatever the non-pharmacological measurements we are using, it has to be on the situation based and the patient exceptions. Patient has to accept the thing, then only we can implement. Now came to the ladder. So WHO analgesic ladder, World Health Organization has given a ladder on the basis of which maximum pain management we can do. But there are little I'll just come back once again. But there are some drawback of WHO analgesic ladder. Now, drawback is WHO analgesic ladder is consist of all the medication. So, as we know that pain management, there are 4 pillars in palliative care, like physical, psychological, social, and spiritual. Altogether, it says the total pain. So, whenever the patient is suffering chronically in pain, so they have this 4 components of pain. But WHO analgesic ladder, as they have given only the medications, so they only talks about the physical pain. They are not talking about other 3 components of pain. These are one of the drawback, but they believe that once the patient's physical pain has been addressed, patient is ready to talk to you, and through counseling we can address the patient's other issues as well. So go back to the WHO analgesic ladder. This ladder has basically 3 steps, but some of the books you can find the 4 steps as well. So step one is the non-opioid drug. Step 2 is opioid. Step 3 is opioid, which is mild or weak opioid. And step 2 is opioid, weak opioid. And step 3 is strong opioid. Basically, step 1 used for mild pain, and step 2 is basically used for patient with moderate kind of pain. And if the step 2 is not working, then we switch to the patient to step 3 for the severe kind of pain, which is strong opioid. Now there is one step 4 with question mark, because step 4 is there, which is consist of interventional pain management like nerve blocks, epidural blocks. These all are interventional pain management. But in palliative care patients, as we are dealing with chronically ill patients, and they for undergone this step 4 procedure, the patient need to have some physical fitness, and all the palliative care patients are not that fit, and the step 4 is not that effective also for some of the patients. That's why step 4 is very rarely used for the palliative care patients. That's why palliative care patients we used only step 1, step 2, and step 3. Okay. Now tell me, just all of you, please go to your chat box and please write what are the medications deals like comes under step 1, non-opioids. Please write, or you can even unmute and you can talk. NSAIDs, paracetamol, yes. Diclofenac. Anything else?
Can we give some tramadol?
No. Tramadol is a weak opioid.
Aciclovir.
Aciclovir, yes.
Brufen.
Pethidine is not non-opioids. Yes, Ibuprofen is non-opioid. Acetaminophen, yes. Acetaminophen is like in the class of non-opioids. Okay. So basically, thank you all for your active participation. Yes. So if we see paracetamol, ibuprofen, and all kinds of NSAID, maybe diclofenac, aceclofenac, itracoxib, lorazepam, ketorolac, this all comes under antispasmodics, also comes under non-opioids. These all medications comes under non-opioids. Yes. See, there are non-opioids plus minus adjuvant. If you can see that step 1, step 2, and step 3, everywhere plus minus adjuvants are there. Adjuvants we will talk later, but before that you have to know the non-opioids. So non-opioids are paracetamol, ibuprofen, all kinds of NSAIDs like diclofenac, aceclofenac, itracoxib, lorazepam, and all antispasmodics also comes under step 1, which is non-opioids. Yes. Next is step 2. Step 2 is weak opioids or mild opioids. What are the drugs? So you have already, some of you have written, and I have told that tramadol comes under step 2 drugs. Okay. Tramadol comes under step 2 drugs. Tapentadol, codeine, oxycodone. Tapentadol is available in market in Topal 50, in the name of Topal 50. Okay. So now we will go through what are the nurse's responsibilities for step 1 first. Okay. So step 1 medications for the patient who is getting step 1 medication, for them, the first responsibility is we have to reassess. Periodical reassessment we need to find out the effectiveness of the current treatment. If the patient is getting 2 different NSAIDs at a time, we have to inform the doctors so that one NSAID should be stopped, because otherwise NSAID induced side effect will be there. What are the side effects? Maybe liver function impairment, kidney function impairment, sometimes gastric irritation, and also the patient who has a hemorrhagic patient like bleeding tendency. He has the bleeding tendency, bleeding wala patient. The patient who has a history of bleeding, this patient we should not use NSAIDs, because NSAIDs increases the bleeding tendency. So these are the things we need to keep in mind. Then, if the patient has any kind of kidney function impairment previously, any history of kidney function impairment, liver function impairment, we have to inform to our on-duty doctor so that they should try to avoid NSAID as much as possible. If not, then they should use it with special precautions, like low dose may be used. Okay. If there is any history of bleeding disorder, I have already explained. So they should not go for this NSAID into like administration to the patient. There things we have to inform to the on-duty doctor. And one more thing, whatever the pain medications are written, the timeline, the time has to maintain properly. It happens even in the even every hospital, and maximum of the hospitals these things happens. Suppose at what time, I don't know at what time you people gives your TDS dose at night. Maximum of the hospitals they give at 10 o'clock. 9 to 10. In between 9 to 10 they finish the TDS dose of medication. Suppose one patient, he or she is getting one injection TDS. Okay, so it has to be the timing is written, the timing is written, it has to be 8 hours interval, of course. But if the patient came to actually sister, today my patient wants to go for a sleep little early, so can you please give the 11 o'clock dose a little early. So nurse is also so kind, so okay, ठीक I will give. So she gives 11 o'clock injection at 10 o'clock, while she was giving TDS dose for all other patients. And next morning the patient was suffering from pain, but she has given the injection is 10 o'clock, but it was requested by patient attendance, but she signed in 11 o'clock only. Nobody even knows that she has given it little early. And next morning everybody was going for, okay, this patient was suffering from pain, so let's give another SOS injection. And whenever the doctor's round came, they decided that, okay, whatever the pain medications we are giving, maybe it is not sufficient for the patient, let's increase the dose. Whose fault is it? It's our fault. It's the nurse's fault, because we have given the patient, of course he doesn't know anything, he has just a request. So we could have tell them that no, for the pain medication we have to strictly maintain the time, but we have given it little early, but we have signed in on the 11 o'clock only. Even my colleagues also cannot say that I have given little early. What is the story behind it? But patient was suffering. So these things should not happen. Now, what are the nurse's responsibilities or need to remember whenever we are dealing with step 2 drugs? So step 2 drug has certain limit. Whenever we are using, it has certain limit to use. So like those who already know, they might have knows that strong opioids we can use according to patient requirement, we can increase the doses. It has no limit. According to patient requirement, we can increase. But in case of tramadol, we cannot increase just because the patient is suffering from pain. Even after giving TDS, even after giving QID dose also, if the patient is not suffering, not getting relief, we cannot just increase the dose. Because in case of tramadol, it says that we should not cross 400 mg in 24 hours, but it is for the USA people. But US and other like Western people, their body weight also high, their height also higher than the Indian people. Then they are, for them it's 400 mg. For Indian people, we even never cross 250 to 300 mg. So if the patient is getting 100 mg tramadol TDS, that it is the maximum dose what we can give. Then also, if the patient is not getting pain relief, it is the indication that we have to switch the patient from weak opioid to strong opioids, from step 2 to step 3. Because step 2, the highest dose I am using, but still the patient has not get pain relief. So I have not given, I cannot give the extra dose. I cannot give the any other dose, because it's the maximum dose I can give. It's the ceiling effect. It's called the ceiling effect. In your house, there is ceiling is there. In your room where you are sitting, it's the limitation that from the ceiling to floor, right side wall to left side wall, front wall to back side wall. This is the limitation of this room. If you just cross the ceiling, then you will not be in the room. So we have to be in that limit. We cannot cross the limit. It's called the ceiling effect. Next is step 2 drugs should not be used. Two step 2 drugs should not be used at a time. Like tramadol also patient is getting. By that time, topentadol or codeine also the patient is getting. Though the codeine is not available in Indian market, but still I'm giving you other example that topentadol is there, Topal 50. So somebody is getting, okay, tramadol tablet 50 mg he is getting. By that time also he is getting the Topal 50. So it's not acceptable. You have to choose one of the, only in between these two, you have to choose one tablet. You cannot give the two same class medication at a time. Next is step 2 drugs should not be used with step 3 drugs. It's like, I always give the same example. So for you also, I'll give the same example that you could remember it very easily. Suppose in your hospital, one MSc nurse and one GNM, both of them, they are posted in the same ward for the same patient, okay, for the same group of patients. So now MSc people, they are little advanced study they have done, so they will do that. No, actually, you should maintain this quality, that quality. Okay, the GNM will think that I was running this ward since a very long time. Now you came to me to make me annoyed, no, with this quality, this and that. Previously also the patient was getting relief with this. What is the point of doing that? So they will fight among others and nobody is going to do the patient care. So the step 2 is like GNM. Step 3 is like MSc. So both of them, if you give the step 2 and step 3 drugs at a time, then both of them, they will fight one another, one with another. Okay, it has the agonist antagonist effect. Okay, then pain relief will be not adequate. So these things as a nurse we should remember. Next, step 2 drugs should not use for the children below 12 years of age. So basically for children, for pain, we use NSAIDs, and if NSAIDs is not working for them, we directly switch to step 3 medication. There is no step 2 medication, because for for babies, for kids below 12 years of age, their liver and kidney cell is not that matured to metabolize this step 2 drugs. So because of that, there might be little chance of damage those organs. That's why we always not to give step 2 drugs. But in some of the hospitals, whenever in your setup, like morphines or like any strong opioids, it's not available, or maybe the baby is hypersensitive to morphine. So in this kind of patients, sometimes in in SOS basis, they use tramadol with special precautions. Okay, but generally we should not use step 2 drugs in children below 12 years of age. Next is opioid drugs. The strong and weak opioid should not use at a time, that I have already told you. And the opioid has the common complication, which is constipation, because opioid reduce the gastric mortality or gut mortality. Okay, so because of that, the patients very oftenly they come up with the complications of constipation. But maximum of the even medical team also, they have the thinking that the patient is getting weak opioids, though we know that strong opioids has the more effect in pain management. But in case of constipation, different study is there which suggest that for weak opioids and for strong opioids, their complication as constipation, the severity of constipation is approximately same. So that's why the patient who is getting the step 2 weak opioids drugs should have the bowel regimen, and it has to be like stimulant laxative, because the gut is not getting the stimulus, the stimulus of this peristaltic movement. So that's why they need the stimulant laxative. The normal laxative will not work. Okay, so they need the stimulant laxative, which has the push and push effect. Mush and push means one is the liquid paraffin and milk of magnesia. It helps to make the stool content semi-solid, no? a hard stool to make the semi-solid, but they need some push effect because their gut motility is not there, or maybe it's reduced. So they have, in case of Crimafin Plus, they have that sodium picosulfate. In case of Dalcolex, they have that Dalcolex. What is the preparation? I forgot.
Crimapine.
No, normal Crimafin has milk of magnesia and liquid paraffin, but they need the Crimafin Plus.
Yes. And what about the lactulose? Duplex or something?
Dofalec will not work properly in such conditions. Okay.
Okay.
Really, I forgot the name of that medication. Dalcolex suppository also having the same preparation.
Some Mobicol like something?
Bisacodyl. It's the bisacodyl.
Bisacodyl.
Yes, it's the bisacodyl, because bisacodyl is the drug of choice which has the push and mush effect. So for the constipation with the drug of strong opioids or weak opioids, the patient who is getting strong opioids and weak opioids but having the constipation, for them we should not use any other laxatives, but we should use either Dalcolex or maybe that bisacodyl or maybe Crimafin Plus if the patient is in Ryle's tube. So bisacodyl tablet, if you just crush, it will not that effective, so they cannot take the tablet. So for them, Crimafin Plus with sodium picosulfate, no, Plus has the sodium picosulfate, which is the stimulant laxative. The stimulus is there, so it helps them to overcome from this constipation. Next, come to the neuropathic pain management. So basically, neuropathic pain management, there are also some of the medications we are using. It's like gabapentin and all, but along with that, massaging, hot and cold application, antipsychotic and anti-epileptic drug. If you just search the gabapentin, you can find that it works for anti-seizure drugs, but it has the good effect on neuropathic pain also. So these are the medications which we use in the neuropathic pain. Now, so non-opioids in weak opioids, you can see that the list, what are the things comes under these categories. Then we have adjuvant. You have seen that in the WHO ladder, everywhere plus minus adjuvants are there. So adjuvants is the drug which enhance the effectiveness of primary drug. Okay, so antipsychotic drug, antidepressant, anticonvulsants, and corticosteroids. Anticonvulsants also works in the neuropathic pain properly. So in the first class, I have told you, some of the patient, they have the more than one types of pain. They have nociceptive pain also, they have neuropathic pain also. So for nociceptive pain, if they are getting tramadol, along with that, they need this gabapentin. So this neuropathic component also addressed properly, and the total pain will reduce nicely, and patient pain relief will be adequate. Sometimes corticosteroids, everybody has maybe have the questions how corticosteroids help. So in case of cancer patients, if they have CA ovary with huge mass, maybe the mass is compressing the bowel so that the lady cannot pass stool properly, and because of that she is having abdominal pain. Maybe you are giving the strong opioids and weak opioids also, but she is not getting the pain relief adequately. But if we use the corticosteroids, high dose of corticosteroids sometimes helps to shrink the peritumor edema, and because of shrinking the peritumor edema temporarily, it helps the patients to pass the stool properly, and her pain addressed, indirectly her pain reduced. So corticosteroid also has the some effect in pain relief indirectly as a adjuvant drug. If we see the opioids side effect, though it is the weak opioid, but they have some side effects. It's called sacrum. S is sedation. A is analgesia. Of course, we give any of the medications to get the analgesic effect, but if it is more than the our expectations, then we need to reduce the dose, because going ahead this patient can develop side effect. So that time this analgesic effect also we have to reevaluate how much analgesic effect the patient is getting. C is constipation, as I have already explained. For R is respiratory depressions. So basically different books has written the definition of respiratory depression differently, but in the palliative care setup, we believe that the respiratory rate below 8 to 10, below 10 breath per minute, it's considered as a respiratory depression. So respiratory depression is one of the side effects which of opioid drugs, but if we give the calculated dose properly, this respiratory depression is very rare. U is euphoria or urinary retention. Euphoria is the excessive feeling of happiness. Urinary retention you already know. M means meiosis or myoclonus. Myoclonus, you know, the myoclonus seizure is there. So myoclonus, maybe tonic-clonic jerking is there. Meiosis is the pinpoint pupil. So now those who are working in ICUs, they know that they need to see the patient's pupil, but don't use torch while you are assessing the patient's pupil for opioids, because you cannot differentiate whether it is the pinpoint of eyeball is because of your torch or because of opioids. Please try to see it in the room light so that you can differentiate it whether it is because of opioids. There are also some other side effects, common side effect like nausea, vomiting, and itching also. So thank you so much, and we can have the question answer session right now.
Thank you, Sudip, for the wonderful session. Anybody have any doubts on this session? Please ask him.
Because some of the medications, even it's maybe new for you, so you might have different questions in your mind, and we all are nurses, so please raise your questions so it will be easier for everyone to understand. Okay, because you are going through foundation course. After foundation, you should in the foundation only there should not be any kind of query. Foundation should be built properly. No questions? Then though I can say that my session is either wonderful or either it was so horrible that you could not understand anything.
Sir, I want to ask, patient who is already on oral morphine
Yes.
and they're having a severe pain, like bone pain or anything.
Okay.
So can injection tramadol can be given for effective pain management?
No, madam, because see, in case of bone pain, no, in bone, morphine works only mu receptor, and bone cells has the very limited mu receptors. That's why in bone pain, morphine is not that effective. Along with morphine, you need NSAIDs basically. Okay, NSAID or paracetamol. This is the main drug of choice for bone pain. But if you give tramadol along with the morphine, then your patient's pain relief will not be adequate. Even morphine can't help you. Whatever it was helping before, the effectiveness of morphine also will diminish.
Okay, sir.
Any other questions?
I think no questions. Your presentation is clear to everyone.
One more question.
Yes,
One
yes,
question.
please. Nilo.
Just now,
Yes,
yeah,
sir.
just
Sir,
now.
Gamma will
sorry, we
Yes,
can't
yes,
hear
yes.
you.
Yeah, just now we were talking about the management of pain. If the patient is not able to cope up with the injection what we give, either tramadol or diclofenac, the pain is excessive, means unbearable. In that case, what can we do?
I'm not understanding your question, sister.
We were talking about management of pain, no?
Yes,
So
yes.
there's a patient with whom I came across that she was complaining of lots of pain. We gave tramadol and then after that injection diclofenac. But then she pain is unbearable, excessive, no? So in that case, what we can do? And this patient is hospitalized, means not hospitalized at home.
So actually for this kind of patient, we should go for we should switch the patient to tramadol to morphine. This means step 2 to step 3. And as the patient pain relief is not adequate even after tramadol also, it's better to have the morphine trial, so that whatever the required dose we will come to know immediately, and the patient pain relief will be immediately addressed.
Okay, thank you. Not one more. In that case, if the patient is at home, then can we give morphine, this injection?
So some of the centers, they have the system that they even do morphine trial in home care, but some of the centers, they do that. If they do not do that morphine trial, even they could give more tablet morphine even at home also. So according to the like whatever is available in the patient's area, then according to that the patient can get it.
Okay, thank you.
Sudip, may I add a few
Yes,
things?
yes, please.
Regarding your question, that patient is not getting adequate pain relief with tramadol, definitely you can switch on to the morphine. If injection morphine is not available, then you can try give a oral morphine trial. You
Yes,
can
yes. Oral
give a
morphine
oral
trial
morphine.
also can be given.
Give it. So you can wait. You can give a 5 milligram or 10 milligram. If the patient is on tramadol, then you can give 10 milligram morphine and wait for another 45 minutes and ask them whether the patient is getting adequate pain relief or not. Then you can, based on that dose, you can give 10 milligram 4 hours early on the next day. Do one thing, you can give a phone call and find out whether the patient is getting adequate pain relief with that particular dose. If not, you can assess well, and then you always remember PQRST pain assessment system. Then you can assess the patient score and cite everything, quality of pain, all the things you have to assess, and then you can increase the dose 30 to 50% at a time. Okay.
There are little small formula also in some of the centers. They follow this kind of formula, like tramadol tablet, Ultraset. No, it's available in everywhere. Yes, Ultraset tablet QID is equivalent to 10 mg of morphine Q4H. So whenever the patient is even not getting pain relief with tramadol, this Ultraset tablet after taking QID also, they always start up with 10 mg morphine. So trial always start up with 10 mg morphine, and they keep the patient in daycare for 1.5 hours or 2 hours, and they will see, they observe the patient how much pain relief is there, and according to that they increase or decrease the dose. This is called that a tablet morphine trial, no?
हेलो गुड आफ्टरनून
Yes.
सर सर गाबालिन कब दे सकते हैं हम लोग
Gabalin तभी दे सकता है. Gabalin we can give, the gabalin is the combination of gabapentin, no? So gabapentin basically used for the combination of pain, like patient is having neck knot and he always present up with, basically my pain starts here, but whenever pain is so much of pain, my head also, my whole head starts paining, even this side also I can feel the pain. So these kind of things, if patient explain, that means along with this nociceptive component, neuropathic component also are there. So this kind of patient, along with morphine or maybe tramadol, they always prescribe gabapentin, so the neuropathic component can be addressed.
ओके सर थैंक यू सर
Any other questions?
Hello?
Yeah,
Yeah. I had a patient.
we can hear you. Tell me.
I had a patient who was in severe pain. Then we had no morphine and we had no another alternative. What could be the best management?
Like in such condition, whenever you do not have morphine, but some of the, even in India also, in some of the places they do not have the morphine license, but they have fentanyl patch. Okay, so those who cannot use the morphine, they use fentanyl. So you can either take the alternative of fentanyl, you can calculate the doses accordingly, or either you can shift the patient in such setup where is morphine is available.
Okay.
This is only the two ways.
Excuse
Okay,
me, sir. Can we use with the morphine
that-
and the fentanyl both together?
Yes, morphine and fentanyl, because see, fentanyl has like fentanyl and morphine we can use at a time, because if the patient is on fentanyl, it's a patch, no, we cannot give the bolus dose. If the
Yeah.
after taking fentanyl patch, if the patient is having any what to say, this in between this incidental
Breakthrough
pain,
pain.
suddenly
Breakthrough pain.
any breakthrough pain, so from fentanyl patch we cannot give the bolus, no, so we always
Yes.
give the morphine
That to
dose.
keep the 72 hours, no? In between that period, we can use other opioid or any other pain.
Only SOS basis 1 or 2 doses we can give, but regularly, for regularly fentanyl also is there, morphine is also there, this we
Yeah.
should not do.
Yeah, and other question is that when we are using 2 drugs, painkillers, and even stage 1, stage 2, stage 3, is there any specific gap between giving the drugs within 2 hours, after 2 hours? You told that not to use 2 drugs in the same time, no? And
I told that at a time means for the same patient, same time, tramadol also, morphine also you should not use.
Yes,
Okay.
is there any specific time gap?
No,
Within
there is
2
no
hours, 3
time
hours?
gap
No,
required.
we can decide, no?
There is no time gap required, but whenever you are using like morphine also, fentanyl also. So morphine, fentanyl you should not give at a time, or like for the particular patient you should not use those two things. Either you use morphine, either you use fentanyl.
Okay, thank you very much, sir. Okay.
मेरा बोलने का मतलब वो था, I mean to see that, say that.
Okay.
Anyway, we have a session on opioids next day, so that time we will discuss more about opioids like morphine and fentanyl. So please come up with your questions. Any other questions? So I would like to, yeah, tell me. Any questions? No. I would like to highlight few things regarding today's session. Now we have learned about the management part. Last week we have learned about the assessment part. So after your assessment, you should manage the patient pain. Based on the pain score, we will give him the medications. We are not authorized persons for prescribing drugs, but we should know what drug is step 1, what drug is under step 2, step 3 and all. And also we should understand about the side effect of each medications. Okay, why we need to understand, learn the side effect of medication is when the patient is come to the review, we need to do the assessment. If you know the side effects of medications, you should do the assessment well. Okay, so that is why we need to understand the side effect of each medications. Now, step 1 is NSAID and the plus or minus adjuvants. So NSAID and other painkillers like paracetamol, ibuprofen, diclofenac, as you all said earlier. So you can give for mild pain. And also, if the patient is having neuropathic pain, that medication is not benefit for that patient. If the patient is having neuropathic pain, you should add some adjuvant analgesics. That's like examples: tricyclic antidepressants, amitriptyline or imipramine, pregabalin, or any that kind of drugs you can add. And if the patient is not getting adequate pain relief with the step 1 medications like ibuprofen, diclofenac, or paracetamol, then you can move on to the step 2 analgesic ladder. That is weak opioid, example tramadol. Okay, so here we need to for the step 1 medication, NSAID, the most the common medications which we are using in step 1 is in NSAID. So if when we prescribe a NSAID to the patients, you have to educate the patient well, because that medications has some side effects. So you should instruct the patients well, because the doctors will be prescribing the medications. When the patients come to you, you have to give a proper instruction. Like gastrointestinal ulceration is the gastritis is the most common side effect. And the another thing is renal dysfunctions. If the patient is not taking adequate fluid intake, the patients will get renal dysfunction. One NSAID can cause acute renal failure, because that is very, very important. You have to tell them after that after taking food only, they have to take NSAID, and along with that, they have to take some proton pump inhibitors, and also they should take adequate fluid intake. Okay, so these are the important things you have to tell them. And also, one more important side effect is platelet dysfunction. So these all things you have to keep it in mind. These are the 3 major side effects. One is gastrointestinal ulceration, and the another thing is renal dysfunction. The third one is platelet dysfunction. So you have to keep it in mind all the time. And the step 2 is tramadol. Tramadol, Sudip has explained well, that is the weak opioid. We have to give weak opioid, and you have to assess the patient well. And along with that, you have to give some metoclopramide, like this that tramadol can cause nausea and vomiting and constipation. You have to give some that vomiting control agent like metoclopramide, or any other medications like Emicet or anything. And another thing is you have to the major side effect of tramadol is headache and nausea and vomiting. These are the things you have to keep it in mind. Always you have to give some stimulant laxatives. The tramadol will cause constipation also. You have to prescribe some stimulant laxatives also. So the third the step is strong opioids that we will discuss the next session. We have a session on opioids. That time we will discuss more about that. I think we can wind up today's session. We have no case presentation today. I think we can wind up the session. Sudip, do you want to add anything?
No, thank you. Actually, I'm so sorry. I told if there is no case studies, I'll make some of the one or two case studies for discussion. But actually, I got little late while coming from the duty. So in between my way, no, there was one road traffic accident, and because of that, I made this this traffic, no, and I just
Senior
reached.
told me like.
I just reached 350, like 255.
No issue, no issue. We will discuss on this kind.
Okay. But if
Okay.
I don't know whether I'll be meeting this group. Oh, yes, I'm meeting on 13th, maybe, no? 11th and 13th next month.
I'm not sure, sir. I have to check the schedule because we are having our FCPN Hindi batch starting from next day onwards.
Okay, ma'am.
So I'm not sure if which batch.
Just I'm telling that by chance, if I do not able to take any sessions, or maybe I'm not available there, if you have any questions, you can just tell to Shiva madam, then she will address your questions. Whatever you are facing any kind of difficulty in between the sessions also, though the pain management is finished, but still you can raise, you can clear whatever your like your doubt is. So don't feel shy to bring any questions in front of us, because like whatever you are learning today, it will build your building for tomorrow.
Okay, thank you, Sudip. As Sudip said, please put your questions in the WhatsApp group so that we can able to answer you. If you have any questions in between, please update in the WhatsApp group. Okay, I think we can wind up. Thank you, Sudip, for the wonderful session. Thank you all for joining today session. Thank you.
Thank you.
Thank you all for joining us today.
Thank
Thank
you.
you, Sudip, sir, for that wonderful session. And I'm requesting all to share your case presentation as soon as possible. I have been updating in the WhatsApp group about the same. Please do share it as soon as possible. Thank you all.
Madam Senior, sorry.
Yes, please, ma'am.
I'm so sorry. Can we extend the submission date for the assignment until this Friday? Is it possible?
Until Friday, it won't be possible, ma'am. Like some of you have submitted the assignments. We will be having sessions on Thursday also. So we have to find out case presentations for all the upcoming sessions. We cannot go without a case in each day. Try to submit as soon as possible, like on Thursday or Friday. Okay.
All right. Thank you so much.
Senior, do we get case for the next session?
Yes, we have a case on for next session, ma'am.
Next session. Okay, that's good. Okay, thank you. Thank you.
Thank you so much, Miss Senior. I also would like to ask, because I'm from Malaysia I tried few times to make for the payment, but it cannot be successful. Any other way that I can do the payment?
I will share you the FCRA account details from to which account you can pay the foreign money. So I will be sharing the details with you in WhatsApp or in your email. Will do.
Okay, thank you very much.
Thank you.